What is occupational therapy really? It's a question I get a lot, and the name can be a little confusing. People often think it's about helping someone find a job or get back to their career. While that can be a part of it, the word occupation here means so much more. In the world of OT, an occupation is any meaningful activity that a person wants or needs to do in their daily life. This could be anything from the simple act of brushing your teeth in the morning to preparing a meal for your family, playing a sport you love, or yes, even performing your duties at work. It's all the things that occupy your time and give your life purpose and meaning. At its core, occupational therapy, or OT, is a client-centered health profession that helps people of all ages participate in the things they want and need to do through the therapeutic use of everyday activities. Imagine you've had an injury, an illness, a disability, or are facing a mental health challenge. These things can create barriers, making it difficult to do those everyday activities we often take for granted. An occupational therapist, or OT, is like a skilled problem solver and coach. They work with you to break down those barriers, find new ways to do things, and help you regain your independence and improve your quality of life. It's a holistic approach that looks at the whole person, not just their diagnosis. The goal of an OT is incredibly personal and unique to each individual they work with. To do this effectively, OTs have different frameworks or approaches they can use, including the top-down and bottom-up approaches we're exploring next. Let's start from the top. The top-down approach is exactly what it sounds like. It begins with the big picture. When a therapist uses this method, their first question isn't about the specific physical problem or the isolated skill that's missing. Instead, they start by asking, what are the important roles? What are the meaningful activities you want or need to do? It's a conversation about life. The focus is on the person's identity, their goals, their daily routines, contexts in which they live, work, and play. The therapist wants to understand the end goal first, the destination. Think of it like planning a road trip. First, you decide your destination. I want to go to the Grand Canyon. You don't start by checking your car's tire pressure or analyzing the engine's performance. You start with the goal. Therapist and client identify key occupations being impacted. Example, cook dinner for your family again. Example, participate in art class without frustration. Those outcomes become the starting point and guiding star. Once the main goal is defined, the therapist works backward. They observe the client doing the activity in their natural environment. They analyze performance and ask, what barriers are getting in the way? Then they look at underlying factors, memory, physical strength, coordination, or the environment itself. Assessment is driven by impact on the meaningful activity. In essence, top-down is holistic and client-centered. It prioritizes life roles and desired activities above all else. See the forest before examining the trees, making therapy immediately relevant and meaningful from day one. Now, let's flip the script and look at the bottom-up approach. If the top-down approach starts with the destination, the bottom-up approach starts with the vehicle. This method begins by focusing on the foundational components and client factors that are limiting a person's ability to function. Instead of first asking, what activity do you want to do? A therapist using this approach might first ask, what are the underlying problems with your body or mind? The primary focus is on identifying and remediating deficits in specific skills: range of motion, muscle strength, grip, balance, attention, memory. Think of it like building a house. You don't start by putting the roof on. You start by laying a solid foundation. You make sure the concrete is set, the framework is strong, and all underlying structures are sound before you think about the walls or the roof. In occupational therapy, the bottom-up approach works similarly. The therapist conducts assessments to measure specific isolated functions. They might use a goniometer to measure exact degrees of motion, or a dynamometer for precise grip strength readings. The therapy plan addresses these identified deficits through targeted exercises. The underlying assumption is that if you can fix the foundational problems, the person will then be able to perform larger, more complex activities. For example, a therapist might have a client squeeze therapy putty to improve hand strength, or complete pegboard activities to enhance fine motor coordination. These are not necessarily whole, meaningful occupations in themselves, but therapeutic activities designed to restore specific impaired functions. This approach is often heavily influenced by a medical model, where the goal is to diagnose and treat the underlying pathology. It provides a structured and measurable way of therapy. progress can be easily tracked through objective data. While it may seem less personal initially, it provides a systematic and scientific way to address fundamental building blocks necessary for meaningful occupations. Let's make this real with a story. Meet Maria, a 68-year-old grandmother who recently had a hip replacement. Her greatest joy in life is gardening. It's her passion, her connection to nature, and how she provides fresh vegetables for her family. After her surgery, she's fearful and in pain. The thought of bending, kneeling, or carrying a watering can seems impossible. She tells her occupational therapist, "I just want to be able to work in my garden again. That's all that matters to me." This is the perfect scenario for a top-down approach. The end goal, gardening, is crystal clear. The therapist doesn't start with leg-strengthening exercises on a therapy mat. Instead, they go to Maria's actual garden. The therapist observes as Maria attempts simple gardening tasks, analyzing the whole activity in its natural context. They see she has trouble bending to pull weeds, feels unsteady carrying a heavy watering can, and can't kneel on hard ground. The intervention plan is built around gardening. The problems aren't just weak hip muscles in isolation. Suggest installing a raised garden bed. Introduce long-handled weeding tools. Introduce a lightweight hose instead of a heavy watering can. They practice these new strategies together, breaking down getting up from a gardening stool. Exercises are embedded within the task itself. Sessions are focused and motivating because she's working on what she cares about most. Progress isn't just degrees of hip flexion, it's the number of tomato plants she can water, the row of carrots she can weed without pain. The focus is her role as a gardener and reclaiming that part of her identity. Now, let's look at the other side of the coin. Meet David, a 45-year-old accountant who has just had a stroke. The stroke has significantly affected the right side of his body. He has very limited movement in his right arm and significant swelling. When the OT first meets David, he is overwhelmed. He can't think about work or hobbies. He can't lift his arm, open his hand, or even feel things properly. Here, a bottom-up approach is the most logical starting point. The therapist's initial evaluation focuses on fundamental client factors. They use a goniometer to measure range of motion, shoulder, elbow, wrist, fingers. They assess muscle tone, measure hand circumference to track edema, and perform sensory testing. The initial problems are clear and measurable: severe weakness, limited motion, swelling, sensory loss. Before David can think about typing or holding a coffee cup, these issues must be addressed. Early therapy focuses on component skills. Passive range of motion exercises prevent stiffness. Specialized massage techniques and compression garments reduce swelling. Motor imagery exercises stimulate neural pathways. Textured surfaces provide sensory input to wake up the nerves. These activities are the building blocks. They're not the full occupation of being an accountant, but they're essential prerequisites. The therapist's goal is remediation, to restore underlying function. Progress is tracked meticulously. 5-degree increase in shoulder flexion, 1 centimeter reduction in hand swelling. As foundational skills improve, the therapist integrates them into functional tasks. But it all started from the bottom, building a stronger foundation first. Every approach has its strengths and weaknesses. One of top-down's greatest advantages is that it is inherently client-centered and motivating. When therapy starts with the client's own goals, they are immediately more invested in the process. This relevance leads to better participation and outcomes. It directly addresses real-life problems from day one. It answers the client's question, "Why am I doing this?" with immediate clarity. Another major pro is that this approach is highly functional and contextual. By practicing in real-world settings, clients learn directly transferable skills. There's no gap between clinic and home. This method encourages creative problem-solving and adaptive strategies, often leading to faster independence. It respects that there are many ways to accomplish a task, focusing on what works now. However, the top-down approach does have downsides. It might overlook the underlying cause of functional limitations. By focusing on compensation, a therapist might miss opportunities to remediate the root deficit. For example, providing a button hook solves immediate dressing problems but doesn't improve actual hand dexterity. It can sometimes be a patch rather than a cure. This approach can be difficult to justify to insurance companies requiring objective, measurable data. It's harder to quantify progress when the goal is improved participation. Documenting adaptive strategies is more subjective. It requires clients to identify and articulate goals, which may be difficult for those with cognitive impairments. It may not be suitable for very young children or those in acute stages of illness. Now let's examine the pros and cons of the bottom-up approach. Its primary strength lies in focusing on remediating the root cause by targeting specific underlying deficits. This approach holds potential for more complete or widespread recovery. For David, simply adapting accounting tasks wouldn't help his arm recover. Bottom-up focus on reducing swelling and facilitating movement aimed at restoring the limb itself. It's about repairing the tool, not just finding different ways to use the broken one. Another significant advantage is that this approach is highly structured and easy to measure. Strength, range of motion, balance scores, processing speed. A therapist can clearly chart improvements. This data is valuable for tracking progress, adjusting interventions, and communicating with healthcare professionals. It's the language insurance providers understand, making reimbursement easier. This scientific framework provides solid, evidence-based foundation, especially in early rehabilitation stages. On the flip side, a major criticism is that it can be reductionistic and disconnected from the client's actual life. Exercises like stacking cones or squeezing putty can feel meaningless and boring, leading to poor motivation. There's no guarantee that component skill improvements will translate into daily occupation performance. A person might regain full shoulder range of motion in clinic, but still not know how to sequence movements for dressing at home. This is known as the transfer of skills problem. A purely bottom-up approach can feel impersonal and neglect the client's personal goals and priorities. A client might feel like just a collection of deficits to be fixed, rather than a whole person with life and identity. It can delay meaningful activities until components are fixed, which may take long or never fully happen, failing to address immediate functional needs. So how does a therapist decide which path to take? The truth is, it's not an either-or battle. The best occupational therapists don't stick to one camp. They keep both approaches in their toolkit and blend them based on individual client, the setting, and the stage of recovery. Know when to zoom in on details and when to zoom out for the big picture. The decision is clinical reasoning. Bottom-up fits the very early or acute stages. Think, David right after his stroke, or someone in intensive care. Fundamental physiological needs are paramount. Address severe weakness, swelling, joint contractures, alertness. They may be too ill to consider life roles. Bottom-up lays critical groundwork when deficits preclude functional activity. Top-down becomes primary when the client is medically stable and can participate in goal setting. Ideal settings, outpatient rehabilitation, home health, mental health, school settings. This is where Maria, the gardener, fit in. Her post-surgical hip was healing, her barrier was reintegrating meaningful occupation. Also ideal for chronic long-term conditions. Shift focus. Enabling participation, improving quality of life through adaptation and compensation. Most clients benefit from both approaches. An OT might start with David using stretching and motor control exercises, building the foundation, then pivot to top-down task. Stabilize a bowl with the recovering arm, stir with the other hand, practice the occupation. This integration is key. Therapist constantly asks, build more foundational skills now, or practice the whole task. The choice is fluid and guided by the client's needs and progress. The best therapists seamlessly blend both approaches, ensuring every step is purposeful. They move between fixing the engine and planning the destination, providing exceptional client-centered care that gets people back to living. In the end, the debate between top-down and bottom-up isn't about which approach wins. It's about understanding that both perspectives are essential for providing comprehensive and truly effective occupational therapy. They are not opposing forces, but rather two different lenses through which a therapist can view a client's situation. A purely top-down approach might help someone function, but could miss key opportunities for physical recovery. A purely bottom-up approach might restore a muscle, but fail to help reintegrate that skill into life. The real magic happens when these two viewpoints are integrated into a single, unified vision for the client. This integrated approach allows therapists to be both scientists and artists. They can use the bottom-up lens to scientifically analyze and treat specific impairments with evidence-based techniques, precisely measuring progress. At the same time, they can use the top-down lens to view the client as a whole person, understanding their story, environment, and what gives life meaning. This artistic, empathetic side ensures interventions are relevant, motivating, and aimed at the ultimate goal, a satisfying and purposeful life. For anyone receiving occupational therapy, understanding these approaches can be incredibly empowering. It helps you understand the why behind your therapy activities. If your therapist is having you stack cones, understand it as bottom-up strategy. If they're helping rearrange your kitchen, see it as top-down strategy. Knowing this allows you to be a more active partner in your care, ask better questions, and collaborate on meaningful goals. Ultimately, the best occupational therapists operate with a flexible, blended model. They begin with the person's story, the top-down view. They listen to what matters. Then, they use their clinical expertise to look deeper, to see what foundational skills need to be addressed to help achieve those life goals. They move seamlessly between fixing the engine and planning the destination, ensuring every step of the journey is purposeful. This dual focus is the hallmark of exceptional, client-centered care, and it's what makes occupational therapy such a powerful force for helping people get back to living. By understanding both approaches, we can appreciate the full scope and impact of occupational therapy. Whether building from the ground up or starting with life's bigger picture, the goal remains the same: helping people participate fully in the occupations that give their lives meaning and purpose.